Well, good afternoon, everyone, and welcome to our Multi-Modality Imaging Conference. You're in today for a treat, because I know you're viable in the audience, but we're talking about myocardial viability. And the treat is, this is a three-part presentation looking at all the imaging modalities pretty much as to where do they fit in the area of myocardial viability. And I think we'll have some questions as to how important this clinical question is, because as our interventions, be it percutaneous or even open heart surgery, becomes less risky, the issue becomes less germane as to day-to-day evaluation of patients. However, there are still areas where we still need to identify whether there is significant viable myocardium from a prognostication, but most importantly from a management point of view. So if we go back to, believe it or not, 1982, in a way a first demonstration from Dr. Rahimtullah as a case example, believe it or not, from the early days of even bringing the concept that there is some reversibility of the myocardium, myocardial dysfunction. We're not talking about here an acute coronary syndrome and myocardial stunning, but in a chronic situation, chronic ischemic left ventricular dysfunction, where you can have significant improvement in ventricular function. And over the years, things have evolved so much from modalities point of view to take a look at that viable myocardium, from even pathology point of view, from a mechanistic point of view, as to what is this underlying situation where you can have significant ventricular dysfunction, be it regional or global, and in somebody who apparently is rather stable or in a steady state situation where they're not complaining so much of angina, maybe a heart failure situation, and then you revascularize or alter medical therapy in a way that ventricular function improves significantly and at times dramatically. So that's what we're going to go with today, is to look at the various modalities. I'll address echocardiography, Dr. Mahmarian will address nuclear, and Dr. Shah will address CMR, which really is becoming the modality to evaluate myocardial viability, because it's really the only one that can image a scar, replacement fibrosis, and the others would infer it, would look at various properties of the myocardium. So what's the goal? Identify patients that would benefit from revascularization. Now, at times people who have angina and other things, that they have viable myocardium, but here the big question is really number 3, which is, in advanced congestive heart failure, help decide management, revascularization versus some other form of therapy which is very different, which would be EVAD or transplantation. Because there are techniques that are quite specific in telling us about viability of the myocardium. There are techniques that are quite sensitive. So in those situations, I think people would err for some specific techniques to go forward with that evaluation. So, and this is our armamentarium, if you will. 1, clinical parameters and ECG. Angina we talked about. ECG we'll talk briefly about. PET. We don't use it much here. It has been in the past the gold standard because it looks at metabolism, but believe it or not, the other competed techniques have done, I would say, rather as well in this situation, particularly nuclear and the magnetic resonance imaging. One thing for our fellows, and I think in general, believe it or not, the electrocardiogram is important. It is actually quite specific. If you see a normal electrocardiogram, and I'm talking here normal without Q waves, etc., in somebody who has ischemic left ventricular dysfunction, meaning you have significant coronary disease and multiple distributions usually, or in a single large distribution, where we've done work in the past when Dr. John was with us, looking at the specificity. If there are no Q waves, it is quite specific in the 70% range, which is, as specific as you can get nowadays in this field of myocardial viability and recovery of function. So on rounds and in the clinic, look at that. You have to put it together, obviously, with the patient situation, because you could have a non-ischemic dysfunction, cardiomyopathy, where that would really not help you. So for echo, let's address echo in the next few minutes. What can we do? What do we do? Usually we look for contractile reserve with dobutamine stress echocardiography, emphasizing the lower end of a dobutamine stimulation. It might sound paradoxical for you to start with, meaning I'm giving an inotropic stimulation in somebody who has supposedly ischemic LV dysfunction, right? And then if coronary, if the absence of coronary flow reserve is the etiology, how can you improve ventricular function even at low doses? Actually, it does, because there is downregulation of the myocardium with many humoral effects, etc., that you still have some contractile function that you could see, and that has been demonstrated in many studies, including some of ours here. So if you look at a dobutamine stress echocardiogram, let's see if we can play it here. That's what you'll be looking for. You're really not looking at just starting at 10 mics or 30 mics. You want to start at lower doses. Here we start at 2.5 or 5, depending what the myocardium is, what the dysfunction is, and look at whether significant improvement, as you see here, in function occurs in certain areas, and others may have what's called a biphasic response, where you have an improvement and then lowering. And that biphasic response is not at a particular dose. It may happen at 5, 7.5, whatever it is, and you could see here when is this improvement, maximal improvement in function. It occurs between 5 and 7.5 mics per kilo. And what do you see when you have an ischemic heart disease with some dysfunction that you're giving a dobutamine? You can see a biphasic response where you have improvement at low doses, at this low dose, and then worsening. And this is typical of ischemia, right? Even typical of ischemia without dysfunction, right? And that's what dysfunction occurs. You can have no change in this akinetic or hypokinetic segment. You can have what seems to be paradoxical. Say, why would you have just sustained improvement? You're not inducing ischemia whatsoever in a dysfunctional myocardium. It's almost like a cardiomyopathic situation, a previous infarction or tethering basically of the myocardium. And some that may have just straight worsening, no reserve whatsoever. Ischemia starts at a very low dose, and that, in our experience, has been the minority. What does it imply? Well, the implication for recovery function after revascularization, we've done this many, many years ago now. It's almost, 20 years ago, when Imran Afridi was with us. A biphasic response has the highest predictive value of recovery, meaning that you have some contractility reserve, and then you have ischemia. So if you take away that, coronary stenosis limiting flow, the likelihood of recovery function is more than 70%. If you have pure ischemia, you may have some improvement. If you have no change or improvement in function, if you revascularize, you're not going to expect that revascularization to really improve resting function or even stress function, because there's no induction even of ischemia to start with. And you can play around with this, meaning if I look at just a very specific response, a biphasic response, my likelihood of recovery, my specificity would be higher. If I look for any improvement, including some of those that may not necessarily imply recovery of function, you'll have an increase in sensitivity at some expense of specificity. But still, overall dobutamine stimulation, contractile reserve stimulation, if it is present, is really a rather overall specific response. It's not very sensitive, it's just a specific response, and I think that's inherent also to the physiology. Now, you could use quantitation. This is strain imaging. And there are a few studies, and this is from Tom Marwick's group, looking at strain rate imaging or strain, basically quantitating what you see with the eye. And basically, you can reproduce what we just talked about here in the eye, looking at changes in strain and strain rate. And this is the multivariable predictors of viability with dobutamine stress echo, augmentation of wall motion. So this is the visual augmentation in wall motion. Strain rate at low dobutamine, also predictive, and the change in dobutamine. So your eye is still very helpful, but you could quantitate it. And most people, to tell you the truth, do not do the quantitation. They go by qualitative changes from rest to low doses to higher doses of dobutamine. From a safety point of view, nowadays we really prefer not to go to the 40 mics, etc., particularly if the ventricle is really very bad. So yes, you'll take away some of that specificity, but I think we've seen some cases where VTAC was induced. These are a minority, but I think with other situations or other technologies that can give you that information, I think we're shying away from this maximal, high dose 40 mics dobutamine and atropine to be able to induce the ischemia and looking at the lower doses. Another thing that you could use, believe it or not, is thickness of the myocardium. And I know Dr. Shah had a beautiful presentation that although overall it works well, there are some situations where it may not work well. But let's go through that. So the classic teaching is if you have a very thin myocardium, usually less than 5 millimeters, so it's a very thin myocardium, particularly if it is scarred by ultrasound, meaning very refractile, that it would impart less viability. And these are, again, data from our institution here, looking at nuclear on the right side and the wall thickness and diastolic wall thickness on the left. They mirror image each other. If you have a normal nuclear uptake, you have normal thickness of the myocardium, viability obviously is very high, and then the more akinesis and dyskinesis you have less nuclear uptake and also more thinness of the myocardium and diastole. What does it mean? Well, it means actually, believe it or not, that if you have a cutoff of about 0.6 or so centimeters, 6 millimeters of the myocardium, which corresponds to about 60% of nuclear uptake, and this is rest redistribution thallium, they're almost equivalent in telling you about the presence and sensitivity of, it's not very specific, but it's obviously very sensitive if you go below that cutoff of nuclear. Now, you could combine them, and that's what, you don't sit down and think about it, but if I'm looking at an echocardiogram, I see areas that are very thin of the myocardium, and at the same time, they don't have much contractile reserve. I feel much more comfortable, indeed, that the prediction of recovery of function would not be as good and therefore more specific that this is indeed a completed scar. And this is data from our institution, again, looking at wall thickness. So if you have a normal thickness of the myocardium, your sensitivity is high, specificity is low for recovery of function, almost similar to nuke. And DSE, any improvement? So if you combine a wall thickness and a DSE, obviously you'll improve your predictive accuracy for looking at this. So contractile reserve can be coupled with thickness of the myocardium to hopefully better evaluate myocardial viability. Now, so we talked about that, and I think, believe it or not, this is the vast majority of current applications of echocardiography. Look at contractile reserve, look at the remodeling of the ventricle, and most importantly, the thickness of the myocardium. There are perfusion, contrast echo. We're not using this anymore. Contrast has really not been approved for perfusion, but we've done some work with it in the past. And basically, I'm going to get to the bottom line here. If you look at perfusion with contrast, is rather very similar, and this is simultaneous data obtained in our group by Dr. Shimoni when she was here visiting from the Middle East. So if you look at myocardial contrast quantitatively versus rest redistribution thallium, about the same. High sensitivity, low specificity, as opposed to when you look at contractile reserve, a higher specificity, lesser sensitivity, even with any improvement. And last but not least is we look at this, we don't quantitate it, but I think it's important for you to keep that in mind, although diastolic function is very load dependent. Interestingly enough, we had some experience with comparing our diastolic parameters with biopsies in patients undergoing revascularization, and tells you a few things. That if you have this slow relaxation pattern where you have low E, high A, and therefore longer deceleration time, it is in a way an indicator for myocardial viability. That if you have this slow relaxation pattern, it is an indicator for myocardial viability. And if you look at from a prognostic point of view, those who have a long deceleration time, meaning slow relaxation, have less fibrosis, have better contractile reserve, have a more improvement of EF after surgery. And from a clinical point of view, they did well after surgery, better than those who had a restrictive-like pattern. Their ICU stay was less, New York Heart Association was better, admission for heart failure in the ensuing year was less, and death or transplantation was less. So bottom line, from an echo point of view, and I'm going to stop here so I'll give enough time for the other presenters and for discussion, is nowadays for echocardiography, you look at the ventricle, how remodeled it is, and there are some data. I didn't add them in the slides here, telling us about the remodeling and the effect. However, we look at contractile reserve for dobutamine. Now, most of the time, you look at this without sending somebody specifically for looking at viability, because many of the stress testing that you do are done in patients with some LV dysfunction. So if you look at contractile reserve and the biphasic response, this is a definite indicator for ischemia and viability in those situations. Thickness, I think, is important overall, although there are some situations where if you don't have a scar, although it is thin and the myocardium is almost stretched, it may come back, actually. So it's not an all or none phenomenon, although in the vast majority of the time it does that. Contrast, we don't use as much, but I think it's almost akin, really, to use nuclear techniques, and I think that's much more prevalent nowadays for us to be able to use nuclear techniques. So I'm going to stop here and ask Dr. Mahmarian to come and talk a little bit about nuclear techniques. And we'll have questions towards the end.
Okay, so we're going to talk a little bit about how we use myocardial perfusion imaging to assess viability. And this just shows you a typical myocardial perfusion scan. This is a stress and rest image where we look at the difference in change from the stress to the rest to look for ischemia. And you can see in this particular case, as in many others, we quantify perfusion abnormalities, and we look at the size of the perfusion defect. And we'll talk about the different protocols we use to look at viability, which actually incorporates some of this as well. So when we think about viability, and Dr. Zoghbi has already talked a little bit about this, there are many ways to correlate how you look at viability. One is from a pathologic point of view, looking at whole hearts and biopsy specimens, comparing that amount of fibrosis to what you see on a scan result, for instance, and to do clinical correlations. We actually look at improvement in regional wall motion, global LVEF, improvement in symptom status, exercise capacity, reverse LV remodeling, and also outcome. And many years ago it was shown, these are two different series that were published over the years, showing that if you take patients with depressed ejection fractions and you routinely send those with advanced disease for bypass surgery, only about a third actually improved their LVEF. So from that perspective, there actually is a rationale for the use of viability imaging to better decide who might improve their ejection fraction and actually who might have improved survival. And in fact, this is a nice little meta-analysis that was published back in 2002 by Dr. Allman, looking at both many different techniques, including echocardiography as well as perfusion imaging, looking at patients who got revascularized or didn't get revascularized and whether they were viable or not. And I want you to particularly look at the right side of the screen, because you can see in patients that were revascularized, if they were viable, they had a very low mortality rate, and if they were non-viable, it actually went higher. Whereas if you look at the patients who received medical therapy, if they were viable, they had a very high mortality rate. So the concept here is that if someone is non-viable and they go for surgery, you may actually do worse for them. Whereas if they're viable and you just treat them medically, they will also have a worse outcome, and they should have been revascularized to begin with. So again, this is pooled data looking at echo as well as nuclear imaging, just to show you that. The other issue with nuclear techniques is what exactly are we imaging? So when we do resting perfusion, such as with thallium or technetium, we look at initial tracer uptake, which is flow dependent. When we do rest redistribution thallium imaging, we're actually looking at cell membrane integrity, which is an indicator of viability. Because if you lose your cell membrane, you're not viable. So when we do rest thallium imaging, we're looking at initial tracer uptake, but then we're looking at the redistribution within, over time, viable tissue, and that will only happen if the cell membrane is still intact and the cell is viable. The same thing with technetium-99m. We look at mitochondrial integrity. And when we look at PET imaging, we obviously are looking at differences in metabolism. You all understand that typically the heart, most of the time, in most of the areas, over 75% of the heart muscle uses, at any given time, uses fatty acid metabolism. It only converts to glucose when it is starved from oxygen and cannot undergo oxidative phosphorylation. So those are some of the concepts behind viability. Here are the imaging techniques we use with SPECT. With thallium, we do rest redistribution. We can also do stress to look for ischemia, followed by redistribution and 24-hour late redistribution, which we don't do anymore because we lose so much in the way of count activity that it really doesn't help us very much. You can also do stress, redistribution, reinjection of 1 millicurie of thallium after the redistribution images to look at improvement in underperfused areas. And you can also do this with nitrates, and that's a very important concept because giving nitrates prior to reinjection of thallium allows collateral augmentation and decrease in LVEDP, which allows better subendocardial blood flow and allows thallium to get into those underperfused areas much more efficiently and effectively. Now that can also be done with technetium studies. You can do a stress study with a pharmacologic agent and followed by a rest injection, or you can do stress and then followed by a nitrate-enhanced technetium study. And again, just as with thallium, by giving nitrates, you can markedly improve your ability to identify viable underperfused myocardium. So let's look at some of the data with thallium uptake. First of all, you'll notice that when you have very low uptake of thallium, this is looking at percent in terms of relative percent in the myocardium. If you have less than 40% uptake compared to the normal area in the myocardium, you have an extremely low likelihood of having any kind of viability or improvement in segmental wall motion as a mechanism for defining viability. After that, you can see that it's a relative increase in your ability depending on the counts that are seen. So somewhere between 50 and 60% of normal count activity actually gives you the best sensitivity and specificity. But recognize there's a gradient. So you go from 0 counts to 100 counts. As you go up the spectrum to 50, 60, 70, 80% of normal count activity, you lose sensitivity because you'll miss people who are viable, but you'll gain specificity in terms of those who you say are viable will always be viable. So you just have to keep that in mind, that there's no specific cut point. There is a lot of it. There's a spectrum in terms of what we use to look at viability in any given patient. Now, if you use these different cut points, this is what you see. In terms of looking at rest redistribution thallium imaging, and this is looking at regional function as well as global function, you have about 80 to 90% sensitivity, you have about 50% specificity. You can see the positive predictive value is around 60 to 70%. With nitrates, you can actually significantly improve that. This is looking at augmented thallium re-injection imaging. This is a study we did many years ago. I hate to think how long ago. It's like 20 years ago. But this is where we took patients who actually had an exercise SPECT. They had persistent defects following a 4-hour thallium redistribution image. And then we randomized these people either to a nitrate-enhanced re-injection image versus just re-injection alone. And what you can see is that in the re-injection images, there was significant improvement as compared to just the redistribution, the re-injection without nitrates. And in fact, in this study, viability was identified in 58% of patients with nitrates when nitrates were used compared to only 33% with placebo. So nitrates are very integral, and we use nitrates when we do imaging all the time now in patients who have defects to help us identify ischemic viable tissue. Counts, just as with thallium, like I showed you that nice gradation from 0 counts up to 100 counts, is also shown when you look at technetium. So this is looking at biopsy specimens in terms of viable myocardium based on pathology versus count activity. And you can see that as count activity goes up, there's a greater extent of viable myocardium. So again, there's a gradation. It's not just one specific point on the timeline here or a spectrum. It's a spectrum going from no viable myocardium up to totally viable myocardium, and the more viable myocardium you have, the higher the counts that will be present. This is looking at the ability of technetium using sestamibi to detect viable tissue, and again you can see it's very similar to what you see with thallium. You have sensitivities in the 80s, you have specificities that are in the 60s. And you have positive predictive values somewhere around 70%. This is looking at nitrate-enhanced rest imaging with thallium, with technetium. And so here you can see in this study, this is just showing a control patient and one who received nitrates. You can see how much improved the images are in terms of the counts compared to the control as compared to when the patient received nitrates. And in fact, in this study, 73% of patients were called viable before nitrates, 84% after nitrates, and so 40% of non-viable segments actually changed to viable with the use of nitrates alone. So again, the importance of using nitrates when you use scintigraphic techniques. And what's also interesting in this study is this was a cohort that did not go for revascularization, but the endpoints that they followed over time, over a several year period, were death MI and late revascularization. And you can see that clearly on the right-hand side of the slide, those who had nitrate-enhanced assessments, you were much more able to predict who would survive and who would not, as compared to the just using the non-nitrate enhanced study. And this was also true when you used only hard cardiac events of death or myocardial infarction, because you could say that in people that were viable, ultimately they went on to have revascularization. That would be a large bias. Turning now to PET, we use different ways of looking at viability, and we look basically at mismatches between perfusion and glucose uptake. Okay? So if you look at the top, that's a severe match defects where myocardial blood flow is markedly diminished, as well as FTG uptake in the anterior wall. In the middle panel, you see mild to moderate match, where you have basically the same scenario. The anterior and the septum are hypoperfused, and there's very little glucose uptake. And then you have matched defects, and those are the ones that we consider patients who have viability. So here you have an abnormality in flow, but you have normal glucose uptake, which means that the myocardium is using glucose metabolism. It has substituted fatty acid metabolism for glucose metabolism to sustain itself, and it is viable. And if you look at the data on hibernating myocardium using FTG PET imaging, this is a summary from DeCarli, you can see that patients who are considered viable clearly do better in every study when they're shown to be viable by PET with revascularization than they do with medical therapy. And in fact, this is a nice little study from Rob Beanland's group up in Ottawa, where they actually looked at a trial where they randomized patients either to conventional assessment prior to bypass surgery versus a PET assessment using FTG, where if you had viability, you went for bypass, but if you didn't have viability, you didn't. And what's interesting in this study, even though it was a randomized prospective trial, many of the patients who actually had viability, who had non-viability, still went for revascularization. There were a lot of crossovers. So they actually looked on the left-hand side of the slide of the patients who actually met protocol. And here you can see that when you look at the patients who actually had protocol, the PET methodology in terms of strategy was a much better way of predicting patients who would benefit in terms of long-term survival as compared to the standard SNP therapy of just sending everyone to bypass. If you look on the right side of the trial, you can see that in those who didn't follow protocol, they were the same. There was no change. So if you're going to do a clinical trial, it's best not to have a lot of crossovers. That's number one to keep in mind. I don't know who that is. But the other issue is that it does show, this is the first trial to really look at how PET imaging can be utilized to make clinical decision making and improve outcome based on the results. Now, if we look at all the different techniques that we have, Dobutamine echo, FDG PET, technetium, etc., you can see that all of them lie about the same in terms of sensitivity. You'll notice that actually echo is more specific, and that's been shown in every single trial. The echocardiography is a much more specific, that if you see enhancement in recruitment and you see a biphasic response, that patient is more than likely going to be viable, okay? So, but if you look, all techniques have pluses and minuses, and they all have roughly around the same sensitivity and specificity, barring, just in terms of echo, a little bit less sensitive but more specific. That's for looking at regional function. If you look at global function, you can see that they all pretty much look the same in terms of their ability to detect who will actually have an improvement in ejection fraction. So I want to spend the last few minutes just on what actually affects LVEF improvement. Okay, what actually affects that? And one is the waiting time before revascularization. The other is whether you have any ischemic events after revascularization, because you could be viable if you have an ischemic event, that could affect your viability, right? Incomplete revascularization, some patients go for revascularization and don't have good targets either. So even though they may be viable, they may not actually get an improvement. Graft occlusion, timing of assessment of improvement and functional recovery, because if you were to do an EF assessment immediately post-op, you're not going to see that improvement as if you were to wait a month or two after the surgical procedure. And also, though, there are other things. Extent myocardial that's viable. That's a viable myocardium. For instance, if you have just 2% of your myocardium that's viable, it's highly unlikely you're going to see any improvement. So people have gotten criteria, and most of that criteria from a nuclear point of view sits around 20% of the myocardium. Also the amount of adjacent subendocardial scar, and also the amount of LV dilation. This is some data from George Beller's laboratory many years ago, looking at the number of segments using rest redistribution thallium imaging. And you can see in this study, if you had more than 7 viable segments, you had a much greater improvement in overall ejection fraction as compared to if you had less than 7 segments, so size does matter. This has also been shown with technetium. This is looking at change in ejection fraction versus number of viable segments, and you can see again, as the number of viable segments increases, the likelihood of having an EF improvement increases with it. This is looking at cavity size. Once you get beyond a certain cavity size, I don't care how much viability you have, you're going to have less likelihood of having improvement. So when you get into very large dilated hearts, you're less likely to get improvement even though someone may be viable. That's in terms of ejection fraction. And this is some data from Franz Walker several years ago looking at changes in ejection fraction. And what's interesting in this study is that if you look at people who had an increase in EF or didn't have an increase in EF, there was no difference in survival with ejection fraction changes. But what's important is that anginal status improved, New York Heart Association functional class improved. So there's more than just ejection fraction that's important. Finally, I'd like to say that when you look at meta-analysis, a recent one just published in JNC, looking at 29 studies in using different techniques, using PET imaging, stress echo, SPECT imaging. You can see in all of these different studies, in patients that had viability by any one of these techniques, with revascularization, they did better as compared to medical therapy. And what's also interesting, and that's just showing the different techniques, this is PET and stress echo and SPECT. But what's also interesting is that in those patients without viability, there was no difference. There was no improvement with revascularization. And that's an important concept, and that's why, I don't know if Bill really didn't get into the issue of stitch, but it's one of the reasons why we still all feel that viability assessment is important, because looking at all of the data that has been accumulated over the years, this kind of paradigm has been consistent. These findings have been consistent. So, wrong direction. Hold on a second. So, in terms of SPECT imaging, we like to do rest redistribution thallium followed by some kind of pharmacologic stress agent. It's very similar to looking at the biphasic response you get with echo in terms of identifying ischemia. It makes it a much more powerful technique to look at those who really will improve. We also do nitrate-enhanced technetium studies followed by adenosine stress. Again, the same kind of issue. So for SPECT imaging, that's our standard protocols, and then for PET, obviously FDG still remains the gold standard in terms of assessing viability with that technique. Thank you.
Again, I think a lot of the stuff I'm going to skip over since we've already touched on it. But the idea, one concept I want to leave you with is, if we talk about what the definition of viability is, remember the true basic definition of viability is the presence of living myocytes. Oftentimes we use surrogate markers such as improvement in wall motion, improvement with contractile reserve, all of these things. But remember that the true basic definition is the presence of living myocytes. And ideally, the ideal imaging technique is one that would actually be able to image both viable myocardium as well as image non-viable myocardium, and be able to do it in a very high resolution detailed map type technique. And so if you look at the cartoon on the right hand side, that would be what I would say is the ideal type of viability image you'd want to get, which is one which shows you all the areas that have viable myocardium as well as directly shows you areas that have non-viable or scarred myocardium. And I'll talk about why I think this might be important. So let's talk about how CMR works. All right, so I'm going to take you back now about 15 years ago to 1999, and this is the kind of the initial hallmark study that was done utilizing this delayed enhancement CMR technique for assessment of viability. And this is an animal study here, and what you have actually on the left-hand side is the histopathologic panels, and on the right-hand side is the corresponding MRI next to it. So you can see in this animal where the LAD was ligated, you've created an infarction that you can see on the histopathology, and in fact you'll notice areas of bright or hyperenhancement on the MRI that correspond exactly to those same areas. And in fact, if I show you one of those side-by-side comparisons and blow it up, you can see that what MRI is able to give you is almost an exact match to what you see by histopathology. Obviously, the fundamental difference here is that this requires an autopsy. This can be done in a living human being. So I think that's a fundamental difference. But it's able to give you the level of detail and the level of imaging that you could only get in the past with histopathology. And then from that publication, this actually showing you a very tight relationship between the infarct size by histopathology on the x-axis and the size of the bright or hyper-enhanced area on the CMR, which is shown here on the y-axis. And you'll notice this is done for both reperfused as well as non-reperfused infarction. And this is done anywhere from a day after the acute infarction, 3 days after an acute infarction, or in fact in the chronic infarct setting, which is 8 weeks later. And again, this is done in an animal setting. Let me kind of turn the table now to say, how do we utilize this technique? How do we do this in humans today? So one of the unique things is it doesn't require stress. Viability assessment by CMR really involves placing a peripheral IV. The patient goes into the scanner. We're going to acquire a set of cine images, excuse me, which allows us to look at contractile function and look for regional wall motion abnormalities. We then are going to inject gadolinium contrast, wait about 5 to 10 minutes, and then perform this delayed enhancement CMR technique, which actually then allows us to image, again, the areas of viable myocardium, which with this technique will appear black, and areas of irreversibly injured myocardium, which will appear bright. Now, notice I use the terms carefully because there's obviously a difference between scarred myocardium, which is in a chronic setting, and acute myocardial infarction, which is an acute setting. And I'll show you later on is that this CMR technique appears to work in both the acute setting as well as in the chronic setting. And so that's why the best terminology probably is to refer to it as irreversibly injured myocardium. By simply looking at this, I can't necessarily tell if this is acute versus chronic. Now, there's other clues that we can use to help identify that. But the reality is hyperenhancement will occur in both settings. And actually, if you go back to this, in this publication in the Lancet, you can see, and these are all chronic infarctions. You can see, in fact, in this person who had a known LAD infarction about 6 months ago, or about 8 months ago, you can see an area of hyperenhancement here in the anterior wall. The second person who had an infarct in the circumflex, and we see an area of hyperenhancement here in the infralateral wall. And the third person with the RCA infarction, we see an area of hyperenhancement here in the inferior wall. But the unique feature of this is that we can not only tell that there's infarction present, we can actually tell what the extent of the infarction is. So in the patient on the left, it looks like it's almost full thickness or transmural. The patient on the right, on the other hand, because we have a high resolution map here, we can see that only about 25% of this inferior wall actually shows hyperenhancement. And in this person on the middle, it looks like it's about 50% of the wall thickness is hyperenhanced, whereas 50% of the wall thickness is not. And so again, you have the ability to identify both the hyperenhanced or irreversibly injured myocardium as well as viable myocardium. And because it's a high resolution map, you can actually quantitate the extent of infarction within any given segment. And this from that study is actually showing you even very tiny infarcts with CK rises on the order of 200, a CKMB of 12, you're still able to identify areas of hyperenhancement. So again, the size of each pixel here represents about 1 gram of myocardium. So it gives you the level of the detail and resolution that you're able to achieve with CMR. So let's go on to talk about, so can this be useful now in helping us to predict improvement in contractile function? So this is kind of the classic study design. This has been done with Dobutamine echo. It's been done with nuclear techniques as well, where you take a patient who's going to get revascularization, either PTCA, either percutaneous or surgical. You bring them in beforehand to undergo your viability technique, as well as cine-CMR to look for wall motion at baseline, and then you bring them back at follow-up to look for improvement in contractile function and to see if the findings on your initial scan actually predict the magnitude of improvement in contractile function. And so I'll show you an example case. And here's a person here who, if we look at their cine images, we can see there's moderate to severe LV dysfunction with an LVEF of about 30 to 35%. And you can see there's some regional variation here. For example, the inferior wall looks like it's akinetic, but all areas of the myocardium at least have some levels of dysfunction. Now, when you look at the delayed enhancement MRI, what you'll notice, in fact, is that there's almost transmural infarct here in the inferior wall, especially in the basal segment, as well as a pretty significant amount of infarction when you get down to the apical regions. But notice the lateral wall and the septum really show no to very little infarction present. And in this person, you'll notice after revascularization, especially if you look at the lateral wall, which again, we said there was no evidence of hyperenhancement or no evidence of myocardial irreversible injury. You can see the lateral wall actually from baseline to follow-up actually shows improvement in contractile function. You can see, I think, very nicely on this 4-chamber view how the lateral wall improves significantly, whereas notice the inferior wall and the apical region really doesn't show any improvement from baseline to follow-up. But in this patient, from an overall ejection fraction standpoint, the EF improved from 30 to 45%, again, driven primarily by that lateral wall as well as the septal wall, areas that didn't show any evidence of hyperenhancement on the pre-revascularization scan. So these are the results from that New England Journal paper from 2000, which basically demonstrated this inverse relationship, which is that as the extent of hyperenhancement in any given segment increases, the likelihood of improvement in contractile function goes down. So that on the left-hand side, for those segments that showed no hyperenhancement, there was about an 80% likelihood of improvement in contractile function with revascularization. On the right-hand side, for those segments showing more than 75% of hyperenhancement that we'd call transmural, the likelihood of improvement was very, very low, almost 0%. And then, in addition to that, the bar graph on the very right here shows if you only look at those segments that are the most dysfunctional, if you look at those segments that are akinetic or dyskinetic, and in this case you can see that the predictive value of the technique actually gets stronger, such that for those segments that are akinetic or dyskinetic but have no evidence of hyperenhancement, the likelihood of functional improvement is over 90%, whereas for those segments that have more than 75% enhancement and that are akinetic or dyskinetic, likelihood of improvement is essentially 0. So one of the strengths, I think, is that as you have greater levels of dysfunction at baseline, the CMR technique actually, the predictive value holds up just as well or potentially even better. Now, the question somebody may ask you is, if you look at those example images I showed you where we have such a high resolution detailed map of the myocardium, why is it that the predictive value is not 100%? And I think John already touched on this, which is there's a lot of factors that come into play which affect improvement in contractile function. And some of those could be due to the fact that you may not have achieved complete revascularization. You may have had a recurrent event between the time of the revascularization and the time that you do follow-up imaging. The other question is, what's the optimal timing to do follow-up imaging? You know, in this study I showed you, it was at 3 months. Maybe some of these segments would have shown further improvement at 6 or 12 months. And then I think Bill and Dr. Q have done some work looking at dobutamine echo late after revascularization, showing that some of these segments, even though they don't improve contractile function at rest, they may still improve contractile function with administration of dobutamine after you revascularize them. So again, there's a lot of issues that come into play. And so I think you'll never see a technique which is going to give you 100% positive predictive value. So I think that's an expectation that we should not hold. Now, the other unique aspect, I think, is there's data showing not only in the chronic CAD setting, which is the data I showed you up till now, but the same inverse relationship holds if you look at patients that present with acute coronary disease, so acute myocardial infarction. In this case, we're not looking at hibernating myocardial infarction, rather we're looking at myocardial stunning. But again, the same inverse relationship seems to hold up. That is, there's more hyperenhancement, the likelihood of improvement goes down. And in fact, even further, if we look at patients who are simply getting medical therapy, the extent of viability in any given region predicts the likelihood of improvement. And obviously, as you would expect, as there's more irreversible injury within a segment, there's not going to be a likelihood of medical or improvement with medical therapy as well. The one thing you will notice, though, is that the overall magnitude of improvement with medical therapy is not as high as what you get with revascularization therapy, either in the acute or the chronic setting. Now, so the question then becomes, so if this technique works in both acute and chronic setting, what's the mechanism? What is the mechanism by which hyperenhancement occurs? And so let me kind of take you back to this cartoon here, which basically is describing the kinetics of gadolinium. So gadolinium is an extracellular contrast agent. And as a result, what happens is it really doesn't get into the myocardium. So if I've got normal myocardium with nice, tightly packed myocytes, you'll notice that the gadolinium molecules are kept outside of that. And so within any given pixel of normal myocardium, the volume of extracellular space is low, and therefore the volume of distribution for gadolinium is very limited. Now, what happens in the acute infarct setting? Well, now you have rupture of these cell membranes, and as a result, gadolinium can not only go into the extracellular compartment, but it can actually enter into the intracellular space as well. And as a result, within any given pixel, there's going to be more gadolinium that can distribute to it. And again, hyperenhancement is a basic principle of gadolinium. Gadolinium leads to T1 shortening and therefore leads to hyperenhancement of the myocardium. And then in the third setting, where we have chronic infarction, where we have now a loose collagen matrix, again, there's an expanded volume of distribution for gadolinium because there's an increase in extracellular space between all of these collagen fibrils. And again, in the two scenarios on the right-hand side, you can see there's many more gadolinium molecules per pixel than there are in the patient with normal myocardium. And so therefore, hyperenhancement will occur in both the acute as well as the chronic setting. Now, let me, in the last couple of minutes here, wrap up by talking about one specific special situation, which is in patients who have wall thinning. And this is one scenario, I think, where CMR potentially really stands out. And so I'll show you an example here. This is a cine image of a patient. I think we would all say there's pretty significant thinning of the septal wall. And when we do delayed enhancement MRI, you can see there's also pretty extensive scarring or hyperenhancement of that septal wall. On the flip side, here's another patient where if you look at the septum and the apex, again, you've got pretty significant thinning. But when you do the delayed enhancement MRI, what's interesting is that the amount of bright or the amount of hyperenhancement is actually fairly limited. So there's a small amount of hyperenhancement despite the fact that the wall is thinned out. And in fact, if you were to quantitate the amount of this wall that shows hyperenhancement, it's less than 50% of the wall. So you've got a situation with extensive thinning, but yet limited hyperenhancement. And this person, you'll notice, after revascularization, in fact, despite the fact that there's significant dysfunction and thinning of the wall, actually demonstrates an improvement in ejection fraction from 30% to 50%, improvement in contractility in the anterior wall. And what's most interesting and what's most striking is actually a increase in the thickness of the anterior wall. Pre-revascularization, the wall thickness here was about 4 to 4.5 millimeters. Post-revascularization, the wall thickness now returns to a normal 10 millimeters. And then this actually was just the data that we put together. We looked at a series of patients that presented with wall thinning that went on to get revascularized. And what you find is that if you look at functional improvement, again, for those patients who have less than 50% hyperenhancement within their thinned area, you actually see a pretty significant improvement in systolic wall thickening after revascularization, whereas for those patients with more than 50% hyperenhancement within the thinned area, the change in systolic wall thickening is almost nothing. And in fact, also when you look at remodeling of the ventricle, you look at an actual increase in thickness of the wall. You can see that for those patients with limited hyperenhancement in the thinned area, you can actually see a reversal of that wall thinning. So the wall thickness goes from a mean of about 4 to almost 7 or 8 millimeters. Whereas obviously those patients with extensive hyperenhancement, you can see that the wall thickness really doesn't change significantly after revascularization. So this, I think, is one example scenario where CMR may be useful, is in patients with myocardial thinning. And really, it's the only technique that's been demonstrated to be able to identify a priori patients that may demonstrate reversible myocardial thinning. Now, let me kind of talk a little bit about some of the basic principles. So go beyond, let's go to more of a theoretical world here. And so what I'm showing you here is a delayed enhancement MRI that's done. And this is in a normal. This is one of our fellows who volunteered. So it's a normal patient. Now, well, if you look at the image, you can see that there's no evidence of hyperenhancement here, right? Everything looks nice and black. Now, here's my question for you is, how much viable myocardium is there? Well, the answer to that question actually depends on what part of this person's left ventricle I'm talking about. And so what I've done here is I've actually gone through and contoured the epicardium and the endocardium. And again, this is a delayed enhancement MRI technique in a patient who's normal, who has no areas of hyperenhancement. But in fact, if I take that and just open it up and show you the amount of viable myocardium in any given region, it varies, right? It varies quite a bit. And so, in fact, in any given normal patient, you may have variation in counts or the amount of viable myocardium depending upon where exactly you refer to, right? So I think that's an important thing to keep in mind. So there's some level of variability that occurs normally. And I'll show you another patient who this person actually has had an infarct. You can see an area of hyperenhancement. And in this person, if I do the same exact exercise, I'm only looking at the viable myocardium here. So I planimeter the epicardium, and I planimeter the endocardium, excluding the hyperenhanced areas. This is what it looks like. Now, what I would submit to you is if I showed you this case here alone, or I showed you this case here alone, it's hard, if we're just looking at viability, to identify that there's any infarction present. It's the ability of CMR to show you both the viable as well as a non-viable myocardium, I think, is what allows you to identify that this person actually has a small little infarct here. Simply looking at viability alone, you can't distinguish a small little infarction from just normal variability in viability that occurs throughout the myocardium. So, so let me kind of wrap up here and conclude by saying, CMR, one of the strengths is it's the only technique that's able to image both the viable as well as non-viable myocardium, gives you a high resolution spatial map with very high contrast to noise between the irreversibly injured myocardium and normal myocardium, and doesn't require the use of stress agents, and in fact has the ability to predict improvement both in the chronic CAD setting, acute CAD setting, as well as, in fact, in the medical setting, or in patients that are getting medical therapy. And then it's the only technique that's able to identify reversible myocardial thinning. And so I think the use of CMR goes beyond just predicting functional improvement, but I think it potentially can provide us with physiologic insights into LV dysfunction. And one of the things we'll talk about in 2 weeks is talk about use of this viability technique in patients with non-ischemic cardiomyopathy, and how, again, the ability to identify both the irreversibly injured myocardium and the normal myocardium actually can help us in identifying etiologies of non-ischemic cardiomyopathy as well. And so in the CMR world, we like to use this term called bright as dead. Makes it nice and simple. So thank you for your attention.
John. Questions?
Yeah, so I have one question for Dipan.
I mean, can you, Dipan, come here or whoever?
Because I think it's very interesting the correlations between CMR and nuclear. Because, again, there's this issue of a gradient, right? Where you look at 0% hyperenhancement versus 100% hyperenhancement, and where you look at zero counts in the myocardium versus 100% of normal count activity in the myocardium. And where somewhere around 50% is where you see viability, really a greater likelihood of seeing improvement versus not. You know, in nuclear, we always talk about the issue of looking at not only whether it's viable, but also the percent of the myocardium, of the absolute myocardium that's viable. What data are there in CMR actually looking at what percent of the myocardium has greater than 50% hyperenhancement as a cut point to be able to say, you know, you shouldn't send this patient for surgery, let's say?
Yeah, so that's a good.
Yeah, how
that's
do you
a good
quantitate
comment.
the extent besides thickness?
Yeah, so that's a good comment. So in fact, there's a graph which I didn't show just in the interest of time from that original New England Journal paper where they looked at, on a global basis, improvement in ejection fraction compared to the extent of viable but dysfunctional myocardium. And again, that cut point, if you use a 5% improvement in EF, the threshold amount was about 25% of the myocardium. And that matches, I think, very nicely with what you see with other techniques.
There's a slide that either one of Echo or Lunar showed.
Which shows
Slide that
the same
that was
thing.
published in a study that we did both, Echo and Nuclear, exactly the same, 25%.
Yeah.
So the magic 25%, despite whatever error techniques may have on their own, it's very solid number. You know, that if you have more, if you have 25% viability, you have a chance for improvement.
And that doesn't mean 25% of a segment.
See, but
that means
it's-
that on the
means the
entire
whole heart. That
myocardium,
means the-
25% of the entire heart shows dysfunction but viable.
Right. And that's the other important
It's
point, because it could be normal myocardium anyway. It may not even, so it's really important to make the distinction whether it's dysfunctional and viable as compared to just normal and viable, right?
But the cutoffs also depend on the technology, right? I mean, if you look at Stitch, and we haven't talked about Stitch, I think it's important to say a few words because none of us touched on it. The cutoff for Echo, since it is a specific technology, is about 4 segments. So 4 out of 16, right? Okay. Okay, but if you take a look at nuclear without stress testing, I don't know what it is without stress testing, but nuclear from George Beller's data, 9 segments for you to have an improvement of function. Yeah, 9. And believe it or not, Stitch required 12 segments for viability. 12 segments for viability by nuclear. And despite that, the problem with Stitch is obviously is a great study looking prospectively as to how do you treat ischemic cardiovascular dysfunction, cardiac dysfunction, but it's not randomized for viability. The viability protocols are all over the place, and within that cohort of 600 plus patients, majority were viable. 80% were viable despite the cutoffs being so high. So basically you're testing within a homogeneous group, rather homogeneous group, of a lot of them having viability. And I've written actually an editorial, you could take a look at that in JACC Imaging, either December or so. There was another sub-study from them regarding size of the ventricle. And you can't, size matters, just like John mentioned, meaning the larger the end-systolic volume, the worse the prognosis, irrespective of what you have. But you really cannot test the hypothesis of viability versus non-viability when you have a cohort where the vast majority have viable myocardium and the thresholds being so high, meaning that even if you lower the threshold, it will be 100% of the population pretty much.
Yeah, and another important point about Stitch is that, remember, Stitch was a sub-study of a trial that was not designed to look at the value of imaging in terms of viability, non-viability, and outcomes. In other words, people weren't enrolled and they got randomized to a viability assessment versus a standard assessment, and then either had surgery or non-surgery based on those criteria. Okay, it was a sub-study in which some patients got viability imaging and some didn't. So it's very difficult to see where that all fits in.
So basically, you cannot really discard a lot of data. Some of them were prospective. Yes, I mean the data, the Ullman data, looking at what you do with if it is no viability versus regarding management, has to be toned down. And the reason for it is usually you're not going to send your sickest patients for revascularization despite they have viability. So there are always issues of that. But within the subset of all these viability studies that we have, many of them were prospective, looking if I do something right on that population, what is my threshold for viability? All these you cannot discard looking at that particular population. So you really cannot throw away all the data on viability just because we have a stitched trial.
Have you guys noticed a decrease in the number of referrals for viability assessment after stitch?
No, I can't say I have.
In the Echo Lab, have you guys-
In the Echo Lab, we do less viability studies. Part of the reason I mentioned at the beginning is it's rare nowadays to ask that question because, one, PCI procedures have improved so much, right? Even off-pump surgery, in case you need it, is done nowadays. So the risk of an intervention is much less. Where it really matters is when you have somebody with ischemic LV dysfunction, a lot of disease,
Right.
really advanced class, 3 or 4, and the question is, should you really revascularize this individual, knowing that they're versus going for heart failure advanced treatment of LVAD or transplantation? I really think at this stage, this is the bottom line of where would be important.
Yeah, that's right.
No, it doesn't.
It's
Yeah.
not.
That patient was not part of speech, and those are the real crux.
Exactly. You don't have really advanced necessary. Although their EF was down, I think on the average was about 26, 27%, which is lower than most of the other studies. Part of the reason also that medical therapy and surgery were almost equivalent is many things have changed over time. In medical therapy is much more aggressive. You have defibrillators, et cetera, et cetera, et cetera. So many other things. So, but stitch will pertain strongly to how do you manage patients with ischemic heart disease, LV dysfunction with that functional class.
But I really like your analogy with how, in terms of your strategy, because it really isn't about, in someone with severe LV dysfunction and triple vessel disease, whether you revascularize or go to medical therapy. It really is now, as you say, a question of whether you revascularize or whether you go to some other form of heart failure treatment that's very advanced, whether it be transplantation or LVADs or such like that. Because that's where the big question becomes in terms of the division line, because medical therapy in the less sick patients may be quite acceptable.
And also, for the trainees, et cetera, is once you deal with such a patient, you need all the data. You need the anatomy data for you to be able to make decisions. You need MRI data, hopefully you can get it. Meaning if somebody has renal failure, et cetera, then you're stuck and you have to use other data, be it contractile reserve, nuclear, if you have PET, hopefully we'll have PET, soon, sometime. But I really think you need to have all these data together to be able to make an educated, judgment as to what is the best way, to go after, to manage a certain patient. Any other questions? If not, thank you very much.